Good afternoon, everyone, and welcome back to the Systems and Sustainability Echo. My name is Andrea Roche. I'll be facilitating our conversation today. So glad to see all these faces on our call. Just so you know, these sessions are enabled for live closed captioning if that helps you to attend and participate. If you want to view closed captioning for the session, just navigate to the bottom of your Zoom window, select that show captions option, and you might need to click on the three dots or the more menu on the bottom right corner of Zoom. If you're having any trouble accessing the captions or having audio issues and hearing today's session, just chat directly with Kato with Echo IT. As you saw, we are recording these sessions for later distribution through the Be Well Texas YouTube channel. Know that any information you put in the chat will not be shared on those recordings. As always in our sessions, we do ask that you stay muted unless you're speaking, but we do encourage everyone to speak, especially in the discussion portion at the latter half of the session. If you've joined by computer, you can mute and unmute using that microphone icon in the lower left of your Zoom screen. And if you're on the phone, just press *6. We encourage everyone to join by video for the discussion portion of the session, but it's certainly not necessary. And we're just glad you're here to learn with us today. Because there are a lot of us and that number seems to be ticking up, which is always great. Let's try to keep our comments brief to allow space for others to speak as well. You can also use the chat feature to share comments, raise questions, and share your perspective as well. Just note that no protected health information is allowed in either the chat or our spoken discussions at any point during the session. That includes sharing names, exact dates, relationships, or medical information in a way that could identify a person. To help us with attendance, we ask that you navigate to that chat feature and enter your name, your affiliation, and your email. We appreciate you doing this small step. It really helps us to capture the full record of the session. If you are a Be Well Texas provider, make sure you identify yourself during the session, either by what I just said in the chat, or if you've joined by phone, email that phone number to the Be Well Texas team. We'll throw that email address in the chat if you don't have it. Also, more about the chat. Keep an eye on it. Towards the end of the session, we're going to send out a link to an evaluation survey. Fill that out, give us some feedback on where we're going with these sessions, where you'd like us to go, and also enter yourself into a drawing for a $30 Walmart gift card. So we really hope we get your feedback on that and that you win. Really excited about today's session. We have a great presentation and a great case. Our didactic today is about implementing the crisis response plan model in the SUD setting, presented by Brooke Fina. And after that, we'll have some announcements from the Be Well Texas program, and then hear a systems case from our learning community. So as always, I encourage you to share your questions, share your feedback, share your tips, no matter how big or small, and your guidance for the questions raised by our case presenter today. Remember, we are all learners and we are all teachers in this space. So with that, let's do some introductions. We'll start with the Hub team. Leslie.
Hi, everybody. I'm Leslie Manson. I'm a licensed clinical psychologist, and I worked in integrated medical, behavioral, and substance use facilities for over 20 years. And I do a lot of consulting and teaching about these topics throughout the United States and into Canada. I'll pass it off. Matt, do you want to go ahead and introduce yourself?
Well, thank you. I'm Matt Rosa. Good to be with you all. I'm background is in clinical social work and agency administration and government work. I currently work as a consultant, and I do implementation support. I coach systems and teams in implementing evidence-based practices and in doing quality improvement and process improvement work. So good to be with you all. Kathy, how about you next?
Hello, everyone. Welcome. So I'm Kathy Hudgens. I am a licensed marriage and family therapist, licensed professional counselor. I have been working in integrated care, both mental health and substance use within the medical settings for about 20 years. And I do a lot of work with practice transformation, training. I work with systems and build systems for substance use treatment programs and integrated care programs. And I'm so excited to be with you all today.
Thanks, Kathy. B, how about you?
Hello, good afternoon, everyone. My name is B. Briseida Courtois, and I am part of the UT Health Be Well Texas team. I am one of the directors. I'm the director of Substance Use Treatment Care Services, and happy to be here. Thank you.
Thank you so much. Julie.
Hi, everyone. good to see you. It's good to be here. I am a new face on this ECHO. I'm Julie Parrish. I am the new ECHO program manager here at Be Well, Texas with the Center for Substance Use and Telementoring. A little bit about my background. I'm a rehab counselor by training. So a lot of my work is with homelessness, veterans, caregivers, both with substance use and co-occurring mental health concerns. A lot of that, a lot of research. But anyway, and I will, Andrea.
Yeah, great. Thanks so much. And I'll pass it to our case presenter for today. Paulette, could you introduce yourself?
Hello, everyone. My name is Paulette Banks. I'm a case manager. And so would you like for me to start my case or just I was introducing myself?
Just introducing yourself. That was perfect. We'll come back to you after the didactics and announcements for that case. Thanks so much, Paulette. And Brooke, I'll turn the floor to you if you can introduce yourself, and the floor is yours to begin the didactics.
Absolutely. So let me go ahead and share my screen while I introduce myself. I'm so excited to be here with you all today and got to hear a little bit about who's on the call. My name is Brooke Fina. I'm a licensed clinical social worker by trade. I'm also an associate professor within the Department of Psychiatry and Behavioral Sciences with UT Health San Antonio, and just really excited to share this information that I talk about a lot today with this group. My background is in clinical work and supervision and training. Myself and my group at the Strong Start Training Initiative, that's part of UT Health San Antonio within the department, we have a training program where we train behavioral health providers across the country in different evidence-based treatments for PTSD, as well as suicide prevention, insomnia, related conditions. And so through that work, I've gotten a chance to talk with many, many organizations and support program implementation and some of the systems work that some of the others that are part of Be Well are doing. And so my goals here today are really to share information with you on a specific intervention called the Crisis Response Plan for Suicide Prevention, and think about this type of intervention within a SUDS clinic and some of the organizational or systems related things and procedures that you would want to keep in mind if you're considering implementing crisis response planning. So with that, I have no disclosures to provide to the group. And I'll move to our learning objectives. So like I started to say, my goal is really to help this group think about crisis response planning for suicide prevention. I'm going to share information on what a CRP is. I'll talk a little bit about some of the research support for this, because obviously that's really important. We don't want to be implementing things without research support. So that would hopefully increase kind of your interest to consider implementing this within your system. And then we'll spend a little bit of time thinking about, what are some of the systems procedures that you'd want to consider, and with that, hopefully the benefits of integrating CRP in a SUDS organization or clinic. So I'm going to start here and think about with you all what a crisis response plan or CRP is and is not. And you'll see at the top of the slide, I've included the term safety planning. While crisis response planning and safety planning are marginally different, they're very much have a lot of the same elements. And so as you're thinking about implementing something like a crisis response plan, if it makes sense for you to go the direction of safety planning, I think, much of what we'll talk about today applies. So a crisis response plan essentially is a brief intervention to help individuals survive a suicidal crisis. So it's kind of a roadmap, guided steps of what to do and to follow instead of engaging in suicidal behavior. It's a recommended standard of care for individuals who are identified at risk for suicide-related behaviors. That's marked by the Suicide Prevention Resource Center, as well as Joint Commission. As you all work in SUDS clinics and organizations, there is certainly a higher rate of suicidal thoughts and behaviors, working with individuals who use substances. And so it's really important to consider, how can we support the times, right, when they might go into suicidal crisis. We think about a CRP as a memory aid, essentially. It's kind of like your patient's executive functioning when they start to get that tunnel vision and go down that road of suicidal crisis. The goal is really to kind of do these steps before a full-blown crisis and suicidal behavior happens. And it's an actual tool. So I'll show you that on the next slide. It's not just a set of strategies we might talk through, but we write these down with a client so that they have an actual checklist. And it's personalized. So it's built collaboratively by a provider and a patient. And we're not necessarily putting something on that checklist that isn't going to be valuable to them, or they're going to say that they're not willing to try, essentially. It's also, I think, important to talk about what it isn't. So it is not a contract for safety. So for those of you who've worked in behavioral health care alongside substance use work, sometimes this is a way organizations would consider supporting individuals at risk. Historically, in the mental health field, we thought if we get someone to just write down that they're not going to engage in suicidal behaviors, right, they're committing to that. And they'll be safe in that way. And that, covers our organization's liability. And that's just not the case. There's been research that really says not only is that not helpful, but it also can be harmful to an individual. So something to consider as you're thinking about your organizations and, confirming that you're not engaging in contracts for safety. The other thing that some of the research has kind of looked at, and then there's some anecdotal evidence of this too, is that it's not great if it's pre-printed. So we really believe that kind of the personalized nature of a crisis response plan is really important. And so we want to think about as a system and, clinicians implementing this, that we're doing those steps, we hold those steps, right? And it's really specific for that client and written out in the way that makes the most sense for them. This is an example CRP to the right, so you all can take a look at that, and also to explain the actual content of the CRP. So the first two steps are to, if we were to engage with a client in a CRP, would be to explain the rationale for it, and to provide a way to write this down. Usually we suggest something that's pocket size, right? Because it is a tool that they're going to be bringing with them. And then you see items 3 through 7 are really what's written on the card. And this order matters. What we know from empirically supported interventions for suicide, that we always want to start with kind of self-management strategies first. So you'll see that with identifying personal warning signs, identifying self-management strategies, identifying reasons for living that an individual could think through, and then kind of move on to more external support, so social support, and then crisis services. So that's really critical to the plan. And obviously, if you were interested in implementing this in your system, the training would very much be like, how do you kind of engage in each of these steps, and what are the tips and tricks around those? We won't go into that today, but certainly if there's follow-up questions, I'm happy to answer those. Okay. So moving then to research, the good news story is that there is empirical support for crisis response plans as well as safety plans. This is a snapshot of research to give you some understanding of that. What you're looking at here are 3 randomized control trials where there's random assignment, of course, and that these were crisis response plans done just themselves. So this is an intervention that can be done in a one encounter situation, which is, depending on your setting and where you are, that might be really helpful if it's not a part of kind of attached to other clinical care. So you can see if you kind of look through, there's the study and then the treatment differences, right? Always CRP compared to typically treatment as usual. These are like emergency department population, some military, some civilian, long-term follow-ups to assess. And if you look at the right-hand side, we're always looking at suicide behavior as an outcome with suicide suicide intervention clinical trials. And so you can see that there is a reduction in the rate of suicide behavior for those studies using for the group that received crisis response planning compared to treatment as usual. And then this next slide is additional research studies. And this is when a crisis response plan or safety plan is integrated into other care. So for these 4 studies, this is about integrating a CRP into suicide-specific care. So behavioral health care that targets suicidal behaviors. But I will share with you all that, it very much is done where we use safety plans or CRPs in other types of care for psychiatric conditions. So think about depression, anxiety, PTSD, substance use. And so even though it can be used as a one-session intervention, it also can be used as an integrated approach when you're, for example, engaging in substance use treatment. All right. So now I want to move, since I've given a little bit of background around crisis response planning and its utility and what it means and the research support, let's talk a little bit about system procedures that you might want to consider if you were interested in implementing crisis response planning. So one of the critical things, even though it's not necessarily a part of doing a safety plan or a crisis response plan itself, would be to decide on systematic suicide risk screening tools. Because in order to be able to do CRP, right, we need to know who is coming through the system to do this with. And if we can universally screen, right, that's going to help us to develop a system or a clinic plan to determine, who might receive something like CRP for suicide risk. Naturally, there's training of staff, right, in that intervention that would be really important. And then to consider what are some of the clinic procedures and standard operating procedures to use this. And then to think long-term about developing like an ongoing training plan and sustainability plan. And so my goal for today is to really just get our wheels turning around this. I have some kind of information to share with you all and some like guidance, but really this is more about thinking about these would be the steps that you might consider if you want to implement CRP in your clinic. So the next slide is for you all to have what are standard screening tools for suicide risk. So it's quite possible that you all are using a standardized screener as part of your suicide prevention already, or maybe it's that, depending on how clients come through the system, that they're asked, are you having thoughts of suicide? Are you having thoughts of killing yourself? Are you engaging any behaviors? If it's done verbally, we really recommend considering using a standard screening tool. If we standardize these procedures and these tools, that's going to really help us to support procedures across the clinic, and also, kind of help ensure that no one's falling through the cracks. So here are 3 options for screening that are really brief and really easy, because I appreciate that you all are doing many different things in your clinic environment, not just assessing for suicide risk. So we have like a gold standard screener, the Columbia Suicide Severity Rating Scale. This is 6 questions, right? And that, it would be important to kind of think about in your system what makes the most sense, but these are guidelines for possible decisions for CRP engagement. So, if any of those 6 questions are yes, you might have someone do a CRP with the client. If someone says yes to like the latter items 4 through 6, that would recommend like crisis line intervention. We have the ask, and that is typically implemented in medical settings. It's really short. I think it takes like 20 seconds. It's only 4 questions. And again, here's some possible ways of kind of thinking about when you would implement CRP. We go on for the PHQ-9, which we all know is a depression assessment, but has that item 9 at the end, asking about thoughts about being better off dead or hurting oneself, and that can be used as a screener too. There's no specific cutoff for this, and actually the research kind of says sometimes it's a good screener, other times it's not. So you might consider the first 2 for suicide screening. Okay. Other considerations for screening procedures would recommend screening at that first encounter. And so naturally that might not be being done by a prescriber or like a clinician. And so there's opportunity to think about, training those frontline providers, right, or those who engage with your population. And then there needs to be this interpretation, right? Is a CRP warranted? Do we need a referral to other care? Does crisis intervention, is that required before this person leaves our care? And then thinking about how you might integrate in the system to flag these individuals, to manage CRP, provision of same-day access, and then thinking about what is their overall risk formulation. And does that need to be determined by a prescriber or a clinician to kind of think about what is the care pathway? Of course, we have training staff as well. So one thing I want to offer for you all from a systems perspective is CRP, although has been studied with clinicians using it, right, in those clinical trials, it can absolutely be conducted by non-clinicians. It can be conducted by other care providers. It could be conducted by, intake coordinators, case managers. There's a lot of work being done to teach, like in the veteran space, to teach peers to do a CRP. And so while like the research hasn't caught up with that necessarily, I think there's enough conceptual basis to do that. And certainly in many, many systems that's being done. So when you're thinking about training staff, it would be important to consider who, right? Who might be doing this intervention, or even who should be aware of this. I've put some training organizations here if you're interested in receiving training in CRP or safety planning. And then of course, developing a standard operating procedure for training, even for those who are not going to engage in this intervention, right? Kind of the system procedures around that. Okay. All right. And then this slide is really borrowed from SAMHSA's treatment improvement protocol, their treatment improvement, their TIP tool. And this series 50 is specific to suicidal thoughts and behaviors. And I really liked this as a frame to think more about levels of program involvement and like the core components that might be required, and think about how that you might integrate your own system procedures here. So you can see like in level 1 programs, right, which is kind of the standard that all clinical staff should have, you know, some education and understanding risk factors and warning signs and protective factors. And so here, you know, thinking about this, a crisis response plan could be conducted by any of those clinical staff if that was the choice, and then referred, right, those patients referred on to behavioral health needs. And we think about CRP as like an intervention to like support individuals in suicidal crisis. So it's not going to like solve their problems per se, or obviously, you know, change their substance use, but it's really to help them get through that intervention. And so that is why we would consider training kind of, you know, staff that is not necessarily doing behavioral health intervention to kind of get that support in those times of crisis while connecting them to longer term care or substance use care. Level 2 programs, right? Those have kind of an ability to see clients with higher suicide risk. They include like a licensed provider. I think supervision is really important here. And so here again, you might have CRP conducted by clinical staff and then kind of moved on or supervised by that licensed staff. And then finally, these level 3 programs are really about integrated care with other, you know, psychiatric settings. And again, we think about like you could do a CRP in these systems, and then, you know, those interventions could be supported by those licensed staff. And so my final slide here as I'm wrapping up is just thinking about long-term sustainability. So training in something like safety planning or CRP is about 4 to 8 hours. Kind of a good standard of training is follow-on consultation or support, right? Sometimes organizations provide that. You know, the training would include behavioral practice or role play to get these skills working, and that you could consider standing up internal consultation or support to help with adherence and sustainability, annual refreshers, and, you know, of course, a plan to train new staff. So thanks so much.
Brooke, thank you so much. Terrific presentation. I want to open the room up for any questions. We actually have a couple already in the chat. Christina asks, I've heard about overdose safety plans as a related tool for prevention and harm reduction. Do you have any experience with that tool, or does it have comparable evidence?
So I don't know that tool well, or really at all, and I'm not familiar with the evidence, so it's hard for me to speak to that. I'm wondering if others on the call might have more information on that could share, but I can share certainly like from a behavioral health perspective, you know, when like those warning signs are tied to substance use, sometimes we'll talk with patients about thinking about warning signs for their substance use related to their suicidal thoughts or behaviors, and kind of use this plan to try to tackle both. Yeah, but others might be able to share, like Lindsay, maybe, or Leslie, excuse me.
Yeah, the SAMHSA HRSA actually has a, I believe it's called like opioid overdose toolkit, and it goes over some of the research and the tools and how to utilize them. So I do encourage if folks are interested to go on there. I'll try to do some Googling in the background next really quick to see if I can find some of those direct links and put them in the chat for everybody. And there are actually some counties and states that have recommended overdose safety plans in specific. And so they actually have very specific ones that they have recommended that places utilize for responding to their community needs. So I'll also try to do something in the background really quick and post some of those links. And if anybody else has information, please go ahead and maybe post them in the chat or speak up.
All right. Work that hub magic, Leslie. We'll look to the chat for those links. Kim asked this question. It was earlier in your presentation, Brooke, but I wonder if we can return to it. What about working with clients who have chronic suicidal ideation? Any thoughts? This looks different.
It's an excellent tool for clients who have more of a chronic picture of their suicide risk. Again, like we think about these safety plans as a way to, we think about suicide risk as, there's like a precipitating event, and then kind of clients get into this suicide mode or suicide crisis. And then some of those factors kind of reside and they get out of it and then they come back into it. And that's really kind of the chronicity of what can happen for individuals. So a crisis response plan or a safety plan is try to help them get through those times and not engage in suicidal behavior. But importantly, for anyone with chronic suicidal thoughts, we want to kind of think about engaging them in another evidence-based treatment. So we know, for example, like evidence-based treatment for PTSD actually helps reduce suicidal thoughts, chronic suicidal thoughts. So if they had PTSD, that would be really important. Other evidence-based suicide-specific interventions would be another option, especially for individuals who have chronic suicidal behaviors, right? Multiple attempters and what have you. So hopefully that shapes the question, or excuse me, the answer. Answers the question.
Great question. Thank you. Thank you, Kim, and for the response, Brooke. And if you're not viewing it, pop open that chat and you can see some of those links and resources that Leslie's putting over there. Any other questions for Brooke? Yeah, Lindsay.
So it's not so much a question as, I went through a lot of that growing up, right? I was in and out of institutions for suicide ideation and for suicide attempts. And I think that we often get caught up on that like chronic suicide ideation, but a lot of the time these safety plans will say, well, let's have you not do this, but then they don't give you a skill to replace that with, right? Like for me, I was self-harming a lot. You can't just stop something like that without replacing it with a skill, right? So like I found it really important to focus on not just like what does it look like when I'm getting to that behavior, but what can I do when I get there that is not, that action? What can I do that's going to stop me from maybe doing that, or how can I replace that behavior?
Yeah. And I was going to say, Brooke, I know you're going to say that's exactly what the crisis responses plan is. It's very different from the old school plans, and it actually has an entire section to what are the behaviors, right? Brooke, do you want to say? Sorry.
Yeah, no, I really appreciate that comment, Lindsay. It's really helpful. And yes, like a safety plan or a crisis response plan is really focused on kind of thinking through what are some strategies that have worked in the past, even if they've just worked a little bit of time, right? Because we know like it can be really hard to be in that kind of headspace and just feeling like, oh man, like nothing's working, nothing works. This is just so difficult. And so that's part of it. And then I think it's also thinking about what is the longer term care plan for an individual, right? And really to your point, teaching really good skills to help, because, often, in the suicidal crisis is often about trying to stop pain, right? And if we can kind of support clients in helping them with their pain and helping with skills around, working through that pain, that can be a longer term solution. And both are important, kind of the short term solve, right? To get them be able to kind of do more longer term care. We can't fix everything in one encounter, but we got to give something, right, to be able to do that longer term work. So thanks so much.
I also think it's, one of the other things I talk about as a peer, right? Because we don't do the crisis plan, intervention plan, things like that. It's just really sitting with someone in that discomfort and figuring out, like, a lot of the times I know for myself when I was quote unquote crisis, right? I knew what to say because I'd been through it so much. I knew exactly what to say to trigger the response that I wanted to get. And so really and then at the same time, it seems like as soon as sometimes you say something, people automatically go into those questions of, would you have a means? Do you have a plan? All those things, right? So really, I always found it was so important to really just sit there with somebody and really figure out what what is going on rather than just jumping to those questions, right? Which is kind of a CYOA type of thing, right? If you're an organization, you have to, but really
Well,
them.
yeah. And I'm so glad you brought that up, because actually, I mean, I didn't have so much time to be able to talk about it, and training in something like CRP will give you all more of this, but there's this part before you even jump into a CRP that's called a narrative assessment. And you know what it is? All it is asking the person to tell the story of what's happening to them and really listening, versus kind of that more kind of traditional risk assessment, like how many suicidal thoughts are you having? And, you know, what is the frequency? Like, that's not helpful to anybody. So that narrative approach of listening, of telling the story, of understanding the experience is very much fused with this intervention. Yeah.
Great conversation. Yeah, Lindsay, thank you. And thank you for a really lovely phrase, really compassionate phrase, to sit with people in their place of discomfort. I really appreciate you saying that. Well, let's move on in the interest of time to some announcements from Be Well Texas. Thank you, Cato, for reading my mind. So first, if you haven't met them yet, the Center for Substance Use Training and Telementoring, or CSTAT, provides high quality education and best practices for responding to substance use. CSTAT can help enhance professionals' knowledge and self-efficacy to screen, to treat, and make referrals for people with substance use disorders. Learn more by visiting their website. We'll throw that link over in the chat for you. Next slide. Make sure you claim your CME credit for participating in today's session. To do that, you need to text the code in red to the number in blue. So that code is 10094251 to the number listed in blue. And Cato's already put this over in the chat. You don't need to hear me listing off numbers. Just make sure you do that by midnight tonight. Next slide. And we're excited to announce Texas sessions are back. These are live webinars with expert speakers discussing key issues in addressing substance use in Texas. So join us next Thursday, August 31st from 12 p.m. to 1 Central for a presentation on fentanyl, fuel on the policy fire. To register, visit texas.org/sessions. Again, we'll throw that over in the chat so you can access it. Next slide. We are busy at CSTAT. So they're launching 2 new ECHO programs this fall, including a behavioral health ECHO that's going to be launching next month on Friday, September 29th. And this series is going to continue meeting on the last Friday of each month. We really hope to see you there. You'll see communications about the upcoming sessions in your emails that you get from CSTAT. Next slide. The second program is going to be a recovery science ECHO launching in October on Wednesday, October 18th. This one's going to meet on the 3rd Wednesday of every month. And to learn more about this program or the behavioral health one, just visit the CSTAT website /ECHO. We'll throw that link over in the chat as well. And next slide. We hope you'll join us next month at this series to learn more about building opioid abatement initiatives in Texas. That session is scheduled for September 28th at 12 p.m. Should be a really, really interesting didactic. Hope to see you there. Thank you, Cato. So we're going to shift over to our case presentation for today, and we'll turn things over to Paulette. So, and just a reminder, Cato, we're not screen sharing that case. If I'm seeing, there we go. Thank you. Paulette works with a Texas-based multi-site residential and outpatient substance use disorder treatment center for women. The organization offers a full continuum of services for women who are pregnant or parenting, and this includes uniquely an array of services, including prevention and intervention, everything to treatment, housing, long-term recovery support, and aftercare. Paulette has some great questions for our community today, so I'm going to turn the mic over to you. Paulette, tell us a little bit more about your organization and how this community of learning can help you today.
So yes, just like you said, our community is women and children who are in recovery. My contribution to the community is to manage the cases of women in recovery by supporting them while they manage their sobriety. And we try to encourage them in their person-centered goals, provide non-judgmental help and kindness, all while providing consistent, honest, and firm leadership. Also, we link and coordinate services, resources, and facilitate community groups. Do you want me to go straight into what the challenge is?
Yeah, absolutely. We want to hear about your challenges, any past successes, and any questions you have for this group today.
Okay. So one of the challenges that our organization is facing right now is a financial module. We are a residential facility, like I said, for women and children. Recently, their barrier has been daycare assistance and other financial needs to run the program efficiently. The state has been overwhelmed with applicants, backlogs for like a year, what we found out in our research back in October. They're basically handing out resources or assistance to daycare since November 2022. So from here on out, they're just playing catch up. So our women right now, the barrier is for them receiving daycare assistance. And without daycare assistance, the women cannot find employment. So right now, so the recovery housing goal is to help the women be self-sufficient. That's our goal, and to prepare them for independence after recovery housing. However, due to the unemployment, they are unable to meet their and their children's daily needs, such as toiletries, diapers, hygiene, etc. Also, there's no funding for such things as crafts, supplies, Zoom subscriptions. So it's kind of like a two-part issue that we're having right now. And although I have been able to engage with our team members, and we've been able to come up with, some support. They have been able to support, like with diapers and things like that, that the women need. We also have a stage stage 4, where I feel that we are in active implementation stage, where we are getting the statistics together to find out how long the women have gone without childcare, and then so we can try to find enough funding to try and help those women so that they can get the childcare that they need, so that they can go off and be independent after recovery and while they're in recovery. So some of the things I kind of wanted to say, because this is kind of new for me, I wanted to know, are there any other organizations having, financial barriers to where they aren't able to assist, or help run their facility efficiently as they would like?
Great question and well framed for the group. So we'll open it up for conversation. Anybody have some feedback for Paulette on that question? Folks who are finding maybe financial difficulty covering a full range of services that they feel they might need to provide, or that they not feel they do need to provide. And to expand from that, any questions you might have about for Paulette to help understand the challenges her organization is facing would also be welcome.
Paulette, I do have a question. So when they are in the residence and they have their children, what is the process, or what is the age group that you typically, the children's age group that you're looking for daycare, and what type of processes do you have to get them, the other children who are school age or preschool, to school and after school? So what do they do with the kids there is what I'm asking, and how old are they?
So the children, they range from 0 to 15 years old, or 0 to 17, long as they're, child age group. So once with our program, they're in a treatment center, and sometimes they can do an interview, and then they transition into the recovery housing part of it. And so they are eligible for daycare once they're in treatment. However, they have to find, because we are preparing them for independence, to provide for themselves life after treatment and life after recovery. We want them to build those independent skills, and we're basically depending on them to find jobs so that they can pay their daycare while they're still receiving the support of the program. So the age group is, and you're correct, with the children that are in grade school, kindergarten through. We don't have really too much issues with that, but it's the infancy, the 0 to like 4 years old, because they can't go to preschool. The Head Start programs, they are helpful, but when they're at the younger ages, that's where we're finding the issues.
And those children are with them in the facilities.
Correct.
Okay.
Correct.
Thank you.
This is Leslie. I would love to hear from the community. Have others experienced this? And what ways have you seen your residents, your community kind of problem solve related to this? Or in what ways have you problem solved?
Yeah, who else do we have on who has some program where you are serving women or people with children where their children are in custody with them? And how do you manage that program and those needs?
Hi, my name is Sherry. I'm with Nexus Recovery Center. And we actually have a child development center here on campus that serves the women who are in residence as well as those in outpatient. And so it's also, it also is a standalone child development center in that we receive state funding through child care assistance. So it follows them into even just finding a job or coming to outpatient classes half a day and then going outside to, like, they can still utilize the childcare until 6 o'clock. If, say, for instance, she goes to a 9 to noon group and then from 1 to 5 she works. And so we're able to kind of slowly ease her into that, kind of like what you were saying about self-sufficiency while also being supported and their children being supported. Since we have a Women with Children program here, they're able to go to the nursery immediately. And then those who are school age, we bus to the local elementary school and kind of give them a feel for both the children and their moms, a feel for what does a schedule look like? How do you continue to gain support for yourself and for your kids, because it's equally important for both the whole family to be supported. So
Sherry,
that's what
I have a quick, I'm sorry, quick
Okay, go
follow-up
ahead.
for you, Sherry. How did that program develop? Did it evolve based upon a need and in conjunction with other programming?
Absolutely, because we have the Women with Children program here on campus. We have moms who come in with their children. We also have moms who are pregnant and then birth at a hospital and come back, return with that newborn. And since there's still programming going on for her to attend, the child, I mean, as a newborn, she can bring the baby to groups, but once the baby starts, you know, making noises and wiggling around, then he or she gets to go to the nursery and be cared for there. Our ratio is really low, which is a beautiful thing to see as well. I've personally had my granddaughters attend here because my daughter-in-law really saw that it was a good ratio, it was a good program. Plus, you know, Nana's right next door. So if something happened, you know, she could come help.
I have another follow-up question. Could you describe kind of how you helped with any funding support to develop that or training? Did you utilize grassroots efforts, fundraisers, grants?
We had a grant.
The training. Okay, perfect.
There was a grant, and that building is, we actually broke ground June of '99, and it was the building is named after the person who provided a grant for us. And then it's continuing through state funding. We do utilize that and have the client sign up for it so that it's also a service they can have after they're finished with all Nexus services. They could, as alumni, they can still utilize it, but they could also find someplace closer with that same funding from the state involved.
That's
So and it's wonderful. You know, we are my team here. Once we put the concern out, they rallied around and they're trying to find, you know, funding. We had to put like a little proposal together and, you know, explain what the issue is so they can see it clearly. All of our programs, they collaborate and help one another. They validate that this is an issue and they're willing to find solutions. So we are in the active implementation stage. We're just waiting for the funding. So I just want to see, while we're waiting for the funding to go through, I'm just trying to find out, does anybody else have any, you know, because it does bring about a twofold problem. It's, they don't have daycare, they can't find jobs. And while we're paying rent, you have the rent, but it's the toiletries and things like that. And one of the questions that I was asked, how would I best indicate that we have successfully resolved this current issue? And I said, the stress of me not having to come out of my own reresources is,
that doesn't work.
While I feel proud of being able to help the women, with the toiletries and, diapers, and things like that, it can become kind of a burden, on days like, oh, running short, so I'm just trying to find out what can we do for these set of women right now who are experiencing this problem. And if if I can be honest, when it's not just the substance use disorder that we have to worry about. And so then it comes into, oh, I'm going to sell my daughter's stroller. And then it comes into, oh, I'm going to take pictures online and things like that. So that's why I feel this is a real, problem that I really want to try to get some type of temporary help in place that someone may know about. Because we have the long term in place. I have no doubt that we're going to get to the bottom of this and figure it out. But I just want to know, what can we do for these ladies right now? And again, it's like one of the ladies were talking to me yesterday, and she said that her CPS worker wanted her to leave the facility because she didn't have a job in place. Yeah. And I'm like, even in Texas, it's kind of difficult to find a job, even if you're applying. She was telling me this, she was having trouble, even though she's applying, just getting someone to call her back is an issue. And also they may choose someone over, them. It's not necessarily, they're not motivated, they're not trying. But it's just so many barriers that they're up against right now. And
so I have two answers for the initial question of, before you get the grants, before you break ground and all that, what Nexus did was we hired specific people to watch the children. And so we had one of our classrooms devoted. We still have a half door. It's kind of interesting, but they would take care of the children in that particular room while the moms were in groups. The other thing that happened as far as toiletries go is we had a program director several years ago who was actually the wife of a preacher, and she talked to her congregation and said, hey ladies, grab that purse that's in the back of your closet, fill it with full-size toiletries and donate it to Nexus. And they came in droves, and there are people who want to help, especially women with children who are struggling with substance use disorder, and that they want to be supportive of these women who are like fighting for their lives while their children are watching.
Exactly. And that's one of the things, that's why when it talks about the process stage where I'm at engaging teams and partners, it was basically on me. I really, when you're in a nonprofit, you're like, okay, I was in a scarcity mindset, like, oh, we can't do this and we should do this. But it's like, I have to think big picture. I have to, think outside of, and so that's a very good, that's very good. I'll go to the table and see if that's something that I can do.
Can I make another suggestion?
Absolutely.
I mean, aside from like the community partners, like Goodwill has programs for, people looking for jobs and things like that. Facebook, right? Facebook has a site called Buy Nothing, where it's just neighborhoods of people giving stuff away for free, right? So you can sign up on Facebook for your neighborhood's Buy Nothing site, and then people just give stuff away, or you can ask for items and everything's free on that site. There's a number of sites like that are just, people just give stuff away. And having worked at like a shelter, domestic violence shelter, like especially if you say that that's what you're asking it for, right? People tend to be very generous.
I appreciate that. Thank you so much.
And Paulette, this is Kathy. I've worked with a group that it was a very much a similar residential but smaller, and they co-opt their childcare while one parent was starting a new job. The other mothers, actually, they had someone who came in and taught them about parenting and childcare giving. And so they would help each other, which gave them this feeling of reciprocity and contributing to each other. So they would take turns. So someone would have a night, job, or in the evening, the other ones, and they came together around that. And it was probably one of the most successful sort of sharing type of caregiving I've ever seen.
Absolutely. And we have tried that. It's, you know, sometimes the dynamics of the women don't, and we're talking about women. So we have definitely tried that. We had one young lady who had a night shift and someone was going to take over her child and, you know, daycare, watch her child. I think it's the consistency that they're really not wanting to commit to. We do have some, we have babysitter contracts and things like that, but you know, I'm going to throw that back out there for the ladies to take care of their own and, you know, have each other's back. And I'm going to push for that a little bit stronger.
It was supervised and very organized. And so they had a childcare room where like two mothers would go with their kids. It was like a playroom and they were short shifts. So if someone had a 4-hour shift, or they would just take turns, but they were required to do it as part of their recovery. And it was one of their learning goals was to learn child parenting. And then they were able to practice that, you know, with supervision.
I love that idea. Was there a total amount of children that could be in the room with like state regulated or?
Depending on the ages, that's sort of what I was thinking about your age groups, but there were ages for different ones. And so they really had to orchestrate it because these were there for 6 months. I mean, this was a long term. So, but even for a shorter term, you would want to have shifts and rooms, I think very much like the other suggestion about this is the room where we keep kids, but this was very much a house. And so they, you know, it wasn't like just come over and watch TV with this child. They were learning things to do with the children.
I love that. And I'm going to push for that.
Yeah, and just piggyback on that from Kathy is that a lot of sites actually, and I know some of Kathy's did this too, you can work with local universities that are nearby that actually have child development centers and students, and they can come over and do the parenting training, the child development training, all of that on site, which is really helpful just in general for learning and development. So that could be something to consider as well. I know we're in our kind of wrap up stage. So I just want to ask Andrea, do you want me to go ahead and give a little bit of a wrap up of all the recommendations right now?
I think that's good though. I want to point out just a couple things in the chat, Paula, just in case you've missed them. And that's some recommendations around sort of grassroots initiatives or like we heard earlier, seeking out in-kind donations from the community. Before the session, we'd also talked about sort of small grant programs that might be available from places like the dollar store, Walmart, Target, or Michael's does sort of small grants for crafts activities, which is not addressing, I think, that one of the really big challenges you were talking about, but does address that sort of goods challenge and could be a source of getting resources. But yeah, Leslie, you queued yourself up. I'm going to go right back to you. Great conversation. Could you give us a summary?
Yeah, I'm actually going to defer. Matt, did you want to make a comment right before? I saw that for a second.
Just encourage folks to check the quote from Sherry that I just placed in the chat, which I think is a powerful engagement line. So thank you, Sherry, for that.
Yeah, and that would be great. Actually, a line or a quote on something for a donation request and for some of those grants. But
I will look into it.
Yeah, and just to summarize, we actually had a really great talk today about CRPs, and that's something that people can put into play as well as consider even some opioid safety planning. And we have those tools that are in the chat box and will be followed up on your end email. And then just looking at the overarching recommendations that people made is one, looking at those community partnerships, contacting perhaps universities or other places, or even other types of caregiving agencies, seeing if they would be willing to help, looking at formalizing those types of partnerships and education and training for you all, considering co-oping again, but making it a little bit more formal with rules and training attached related to that. Perhaps contacting those grants, as I know you're already kind of in that process, maybe even current ones that are on board to see if you can reallocate some of the funding that's there, especially in this time to do some emergent needs setting for you related to this in specific. Maybe considering empowering the residents and the folks that are there right now to see what are some other ways that they can work with each other, not only on the co-ops, but on the training, but also maybe seeing if you can leverage some of their creativities to create goods and to really be able to utilize those as fundraisers or other things, or have them help with some of the grassroots fundraisers. Maybe that's part of a job that they could do right now. So they're filling their time, and that's something that they could also do something while they're having their children as well with them to do that. Looking at some of the local spots like their churches, seeing if they would be willing to do a specific effort for you for specific items, as well as those Michael's Targets, things like that Andrea had said. All of those agencies, the local ones, even the dollar store will actually give $20 to $200 a month for specific donations that would be able to give you things for children, for items, for daycare support, activities, things like that. And also all of the resale sites, those secondhand stores, they actually have to toss most of their goods, and they toss them, they throw them away, that people donate to them that they do not use. And so there's a lot of the sites I know here locally that go to them and they get all of that. And then they go through those, and then they do garage sales with them, and they utilize them for their own, obviously for their own support for their residents and community members. And so I'm just checking to make sure I've gotten all of those recommendations. Oh, and also look at perhaps if there's other ways to consider job development, if perhaps any of the women were interested and are individuals that would want to work for caregiving positions. It is actually one of the #1 underemployed positions that are constantly looking. And if they do get employed as a caregiver, meaning as a daycare provider, they often get free daycare, low cost daycare associated with those positions. So you're double filling gaps there. Or maybe there's other types of community efforts where people are willing to give at-home jobs for these women. And sometimes you can find those, but it does take grassroots efforts to even create them. So thank you. Andrea, do you want to say anything more?
That was a terrific wrap up. I want to thank our great hub team and Brooke for the tremendous didactics. Paulette, thank you for sharing such a great case with us today, and really bringing questions to this learning community. And above all, thanks to all of you who keep showing up, sharing your perspectives and your experiences and those strategies for improving substance use care. We'll see you next time on September 28th. Make sure you check the chat. Paulette, there have been a couple more resources shared, a site in San Antonio in Powerhouse, and the rest of you, please note the CME instructions that are shared over in the chat. Thank you all so much for joining us. Have a great rest of your week. We'll see you in a month.
Bye-bye.